If you're studying evaluation and management coding specifically for the updated 2023 guidelines and you just think to yourself, oh my gosh, I would understand this so much better if I just had someone to walk me through a couple of examples, you are in luck because that is exactly what we're going to do today in this video. Hey there, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials because I want you to be successful in your medical coding career. Now, I just finished some video series kind of breaking down the different sections for evaluation and management coding, the different components of medical decision making, different components that we look at for time. And now I actually want to take you through a couple of case studies. I pulled one for the emergency department, I pulled one for an inpatient hospital stay, and then we're going to go over an office related case at the end. And if you want me to do more videos just like this one, you have to let me know in the comments and make sure you give this video also a thumbs up and subscribe and hit the notification bell so that you can get alerts when I post those episodes. Now, I know it can be difficult to do this on the video because it's hard to read all of those notes. So in the description of this video, you're going to find a link where you can download the text files for the cases as well. Sometimes that's a little easier to follow versus just seeing everything on the screen. And keep in mind, evaluation and management is so subjective. The cases that I selected are fairly straightforward ones, but as you're out there working and have longer cases that are more complicated, you're going to see a variance in how coders analyze them. I've seen it compared to like the weathermen. We're all kind of looking at that same outline and scheme. We're looking at the same measures, but depending on who is interpreting that, which weatherman, you might come up with different forecasts of what's going to be happening. So there's this little bit of art and science, especially in evaluation and management coding. You may often find, though, that even though some coders will abstract things from different areas, oftentimes, even though we're saying, I would take this, but maybe not this, you may still come up to the same level. You might say, yeah, this is still a 99214, even though maybe you're looking at things and abstracting different things or analyzing, or maybe saying, well, I wouldn't accept this unless it says this, or I would want the provider to say, this, this, and this. You will definitely encounter, depending on how conservative some organizations want to be, the splitting of hairs of like, oh, well, it says it was read. It didn't say that I personally read. And because this channel tends to target more people that are preparing for certification exams, oftentimes some of the rationale that I will provide for you is more geared towards this is what will generally be accepted in a certification exam scenario, but you can understand you may find variances of interpretations. Some organizations want to be a little bit more lenient with their providers, while others, they're looking at that from an audit perspective. They want everything to be 100% as it says in the guidelines, very, very strict. Now, because I have such an audience that is preparing for certification exams, they're like people that are going for their CPC or they're going for their CPMA or a EMC, which is your E&M coders. You're going to want to be familiar with the E&M audit tool that the AAPC provides, even though there might be some out there that are a little bit more user-friendly or you may prefer. Chances are good if you're sitting for a certification exam and they want you to score out an E&M, the tool that they're going to provide for you for the exam is going to be the AAPC tool. And actually, I don't have a ton of experience using this yet myself, so we might just be learning a little bit together as we go. So this is the case that I have for the emergency department. Pause to read, or you can download it from the link below, but we're going to go through this particular patient is 32-year-old male. They fell while painting their house, and it looks like they have a wrist fracture. We ordered an x-ray. We did a splint. Now, I want to keep in mind, even though there's a lot of things going on, there's an x-ray that could be coded. There is diagnosis that could be coded. For these examples, we're focusing on the E&M. We're only going to be leveling the E&M. Now, in real world situations, you're going to code out the diagnoses and all the other services that were provided. But for this one, we're focusing on the E&M. So don't come at me later on in the chat. Go, why didn't you code the diagnoses? Should have. We're focusing on E&M right now, okay? So we have our three components of medical decision making, and these are kind of outlined a little bit differently than we see on the medical decision making grid like the AMA has or that NAMUS has. The AAPC has this outlined a little bit differently. So we have our number and complexity of problems addressed chart. Over here, we have the risk of complications. And then down here is kind of like and it's not too bad. It's this little kind of like data calculator almost. Now, data is one of the areas where it gets a little tricky. So, a lot of coders, myself included, will score the other two areas first. And if it doesn't look like we have enough data to push that level up further, we kind of don't worry as much about the data. Not that it's not important, not that we shouldn't review it, not that if we're auditing, we shouldn't look at that and give provider feedback. But if we're just productivity coding E&Ms and we're like, yeah, this is a level 4 based off of just the complexity and the risk, we can look at that and go, okay, yeah, this is a level 4. They didn't really look at a lot of data, so I'm not going to split too many hairs over, the little data components if it doesn't look like we're going to get any higher levels based off of them. Not saying that's right, wrong, or otherwise, simply just telling you a lot of the philosophy. Most people will save data for last. So now with this fracture, I think our biggest debate is going to be, are we looking at a stable acute illness or are we looking at a complicated injury? So we might have to go back here and think to ourselves, what is the complicated injury? And I think this one actually does maybe have some definitions here. Let's take a look. So here we have this little definition that the AAPC provides in their audit tool, and I will link that below as well. But in order for it to be considered a injury that's complicated, they're saying it would have to be multiple injuries, multiple fractures, it would have to be extensive. And to me, this fracture does not seem to be quite extensive. This seems to be a pretty straightforward fracture. So I would say this is more low, more the acute, uncomplicated illness or injury. And now we're looking at our risk of complications. So, one of the first things I like to look at is the medications. Are we doing over the counter medication? Or are we doing prescription drugs? Because that's, again, a quick, easy thing to first kind of target, hone in, look at. Is that prescription drug versus over the counter? Or are we looking more at like a high level complex thing? This doesn't look like obviously we're not sending this patient, we're not admitting this patient, we're not afraid that they're going to lose their hand. It looks like a pretty straightforward wrist fracture. And here we can see, if we look at the note, the patient was given IV pain medication. We did a splint on it. We're consulting ortho. Now, if this was a live record, we could probably go in and see exactly what pain medication was administered. I have a hunch, though, that it was probably not Tylenol. We'll say, though, for the purposes of this, let's say we look at it, we see that it was definitely a prescription strength medication for pain relief they were giving. They were giving, morphine or something. We're going to consider that more a moderate risk, especially considering the patient was scheduled for surgery. There are no real minor surgeries as far as fracture repair is considered, so that is more in the moderate category. And again, keep in mind that these are not hard and fast, like, oh, if it says this, it has to be in this. These are examples only. So there is a component of evaluation of the whole picture of what's going on as far as what is the whole risk of complications of that patient management. Now we're down to the dreaded data section. So did we review prior external notes? No. Did we review the results of each unique test? All right, let's see here. Did we review a unique test? So it says X-ray images personally reviewed by me. Now, since he ordered the test, though, that doesn't really count them as a unique test because they're not from someone else. And again, this is probably going to be one of those situations where the data is not going to make much of a level difference. But we will get credit for the one that we ordered. So there's one. And then we didn't do an assessment requiring an independent historian, no extra history from an external sources, independent interpretation of a test. Now, presumably that emergency department physician isn't the person who did the actual x-ray, but chances are good that that emergency department x-ray is getting billed in with all that service. So it's considered something that they're billing out for, right? So if the emergency department is billing for that x-ray code, they can't also then double dip and then bill it the higher level E&M service because of it. So my professional opinion, and of course, again, my professional opinion isn't everyone's professional opinion, but for the sake of argument, we're going to say this one, they billed out for the x-ray. And then in that case, we cannot count it for the interpretation of a test because that is being separately reported by that separate CPT code. They're getting the reimbursement for it right there. And we did not discuss the test with an external physician. So let's see here. We've got 1.1, the overall one. Where does that take us? Let's see. So it looks like they count this as the T and D category. And it says here under their little grid that one T and D is minimal. So we have minimal data, we have moderate risk, and low complexity. Now, if we take a look at our emergency department grid in our CPT book, then we didn't get 2 in the moderate category in order to get it to a 99284, but we did at least meet a 99283. So if we kind of just go back to the AMA grid, we hit the low, I believe, here for the number and complexity, minimal for data, but then we got a moderate for our risk. So even though we didn't get 2 in the same category, we exceeded it here. We met or exceeded in this low because we have a low and then we have one that we exceeded, which means we also met at least this. We exceeded it. So we have 2 in the low, which counts us as a low medical complexity. So here for our emergency department services, low is our 99283. Now, if that's the first time you've ever scored out an E&M case, one of the questions you're probably going to have is when I'm working as a coder, how many of these am I going to have to do like in an hour? It varies by location, but I can safely say at least 10. If I had to wager a guess, it would be somewhere between 10 to 20. Again, that depends on how fast your system is, what other elements you have to look at, or just whatever benchmarks or standards your organization has set based off of how others are performing. Now let's take a look at this next case. It is a subsequent hospital visit. Patient was admitted for acute myocardial infarction, which sounds severe, but when we actually look through this note, we can see this patient pretty well stabilized. They're saying, hey, we're going to discharge them probably in the next day or so, but there's still some things going on. We still actively have them on some medications. We're still just making sure that they are stabilized. But this looks like it's not going to be a high complexity visit. And this patient didn't just have a myocardial infarction. We can see here they have hypertension, they have hyperlipidemia, they're a smoker. They came through the ED with chest pain, and that's one of these things that you have to pay attention to as well, especially with the exam. They're going to trip you up with things like, oh, this patient presented through the emergency department, and they're going to maybe try to trick you into picking an emergency department code, but this patient was admitted. They are on like the multiple day stay, I think like a 3-day stay of being admitted to the inpatient hospital. So we're not coding for that emergency department visit. They were admitted to the hospital. This is not an emergency department visit. This is an inpatient hospital stay. And we can see here they're on some prescription drugs. They're continuing them. They're monitoring some cardiac elements. You could probably cut this a couple of different ways. You could say, oh yeah, we definitely have 2 stable chronic illnesses. We could count it that way. We could look at this and go, this is an acute complicated injury because this is a myocardial infarction. That's not a straightforward thing like a sprain, right? So we could cut it a couple of different ways, but I think we could all agree that this is more of a moderate type of complexity. And while maybe traditionally their primary care physician is taking care of that hyperlipidemia and their chronic conditions, they are now in the hospital. And that hospital service, that hospitalist usually, is the one that's in control of those while they are admitted to the hospital. So they are managing them, and sometimes they have them on a different type of dosage, even while they're in the hospital versus when they are just an outpatient and seeing their family care physician. That's why it's so important to have those transition of care appointments with patients, because there might be, they might be discharging them on a whole bunch of medications, and then they go back to their family care physician and say, hey, okay, you don't need to take these anymore, and kind of manage it from the day-to-day life that patient will be living outside the hospital. So now, again, this is where we're getting more subjective. Can we count this as moderate because we're still keeping them on prescription drugs? Yeah. Is the patient stabilized? And some people might make the argument, no, I think this is, low risk because the patient says they're stable and, it doesn't look like anything's going on. I think we still have enough data here since they're saying to continue these current medications and they're on prescription drugs that we could still count that for prescription drug management. It's clear that this provider did assess and go like, yes, do we still need this patient on these prescription drugs? Oh, and now we get down to our data point. Did we review external notes? It doesn't look like it. I'm not seeing here that there was like a statement from cardiology or a report from them that was reviewed. Review of each unique test. It says that his laboratory values have improved. What laboratory values? Is that because the provider reviewed them? Is that because the nurse told him that his laboratory values? This personally, I wouldn't credit it because it's not saying I reviewed the lab values. I don't see what lab values it is here. He's saying to continue monitoring the cardiac enzymes in EKG, but he's not actually saying that he did review them. I'm not seeing any orders of any tests. I'm not seeing any independent interpretations, nothing saying, I personally reviewed this test. There's some mentions of their involvement with the cardiology department and that they're, having consultations requested, but nothing about a discussion. I'm not seeing any summarization of a discussion. I'm not seeing any, external sources, independent historians. I'm not seeing really anything that I would count for data. But again, this is a situation where even if we wanted to split hairs and go, oh no, I would count this and this, it would not make a difference for the level selection because we already have a moderate level of risk and a moderate level of complexity. So again, if we look at our grid here, inpatient hospital or observation care, 'cause that's right, they combined them both this year. We see our moderate will put us at that moderate category, which is the 99232 subsequent code. Now, I will probably take some heat for this, and I have certainly in the past, where people are like, but they're stable, and really it should be a level 1. When I'm looking at this and I see this patient has multiple chronic conditions, they're still managing them, it still meets that criteria for that level 2. Now, of course, medical necessity, overarching criteria. If you think you have a valid argument for medical necessity being an overarching criteria and that it should be a level 1, totally understand that. But if I was someone who was sitting for a CBC exam and I was presented this note and I saw that this patient had prescription drug management and I saw multiple chronic conditions, I saw they're still monitoring that myocardial infarction, that's that history of that MI, I would probably weigh in on scoring it more the moderate level. If I'm looking at this from an auditor perspective and I'm going, okay, I'm auditing this physician chart, yes, I'm going to scrutinize it more. I'm going to say, continue which current medications. I'm going to say, hey, you should have listed here all of the different diagnoses that this patient has under the plan and which, prescriptions are going for. I think there's definitely some areas where we could give some provider feedback, but again, looking at this at the standpoint of how are we scoring this level more so for general purposes for if you're a productivity E&M coder or someone preparing for a certification exam. Now, this last note, we're going to get a little wild. This is a pediatric patient came in because they have a marble shoved up their nose. Don't shove marbles up your nose. Don't shove marbles up your nose. But this patient did. And they presented to their, I think this might be an urgent care. This might be a PCP. It doesn't specifically say. So when we look at this, this is formatted like a typical office note. We have our HPI, we have our physical exam, we have our impression, our plan, but really look at this for a second. There was a foreign body removal, right? Foreign body, that marble lodged up that nostril, and we removed it successfully. We didn't require anything else. Now, there is a code for removal of foreign bodies from the nostril. Check out the index under removal and then foreign body and then nose, and it directs us to 30330. And you can see here 30330 is removal foreign body intranasal office type procedure. We also have one for general anesthesia, but this wasn't that. This was this office type procedure. Why do I bring this up though? Because this is the kind of thing that they might try to trip you up on these exams. They're going to give you some options where they may say, was it this type of office visit? Was it that 30300 code? Or do you bill both? When we draw out everything that's in here, Like if I were to take this note and get my highlighter and go, I'm going to highlight everything in here that has nothing to do with that removal of the foreign body. Is there anything left over that would be a billable E&M service? This was all related to foreign body in the left nostril. The plan was all related. I mean, there is literally nothing here other than the relation to that procedure. Everything they evaluated was related to that procedure. The history was related to the procedure. There was nothing else. And if we remember our guidelines for our modifier 25, which is when we bill a procedure and an office visit on the same day, it has to be significant. It has to be separately identifiable. And there is nothing significant beyond what we did extracting that old marble out of the nostril. So in this case, we aren't going to bill an office visit code at all, even though we might at first glance look at this and think, oh, this is an office visit. It's a procedure. And there is no office visit outside of what was related to that procedure. Every procedure has a little E&M component in them because obviously you're not going to do something invasive on a patient without taking some history, examining things that are related to specifically that service that you're about to provide on that patient. So that's built into that reimbursement. Again, you have to do something significant, separately identifiable in order to build that procedure code and the office visit code. If they had come in and had something else going on, maybe they had a rash or the mom said, this kid's not been sleeping well for the past several days, or, they were coughing and that wouldn't necessarily be related to that obstruction there, something separate, but there wasn't. There was no separate diagnosis. There were no separate evaluation. This patient had no separate conditions. So in this one, we really are just billing that 30300 code without the office visit. And of course, you would abstract as well that ICD-10-CM code for the marble stuck in the nose. I hope this helped clarify some things for you, even though maybe we wish this was a little bit easier than it is. Certainly respect that. But if you would like me to do more case studies like this or for different services, definitely let me know in the comments below, specifically if you have certain types of cases you would like me to provide. And again, if you like this video, make sure to give it a thumbs up. I will see you guys in the next video. And until then, just keep on coding on.